Welcome to our weekly patient education session. Thank you for being here. So today we're going to focus on your prescription. We're going to focus on the different therapy elements in your prescription that are not necessarily nutraceuticals, elements that do not come from the health food store, elements that come from the pharmacy. And so some of you are very concerned when you see medications which are not strictly naturopathic. And so there's a good reason, there's a good explanation for it. There's a lot of research, there's a lot of experience behind the treatment strategies, and we want you to be fully informed, fully on board. Very well. So there will be 16 elements in your list for most of you, 16 different elements in your treatment list. And a good proportion of them, about 30% of these therapy elements, will not come from the health food store. They're going to come from the pharmacy. And so we want to make you aware of these particular medications. The number one element that we want to discuss is called Xeloda or Capecitabine. This is a chemotherapy agent, and it represents the fact that at the Oasis of Hope, we are not divorced from Orthodox practice. We're only divorced from Orthodox practice where we don't feel that our patients may gain from it. The Oasis of Hope Hospital has been treating patients since 1963, so that's 50-something years now. And I personally have been here for almost 25 years of that time period. And as good as the treatment has always been, as successful as the Oasis of Hope has been in helping our patients, there always has been a remnant, a certain percentage of our patients who require more. Patients in which naturopathic treatment by itself is not enough. So that meant that we had to find a way to make our treatment stronger. We had to find a way to upgrade the therapy, and that's kind of the origin of the best of both worlds approach that we've been doing for many years. Now, in regards to Xeloda therapy, these patients, this is a chemotherapy agent which has a very good tolerance profile, has been around now for maybe 15 years. And it's a drug that is mainly used in colon cancer and breast cancer. It's usually about second line, third line, or even fourth line treatment for these particular situations. So when we had a patient fail to Laetrile, fail to the naturopathic regimen, and then obviously our efforts were directed at trying to reinforce the therapy, upgrade the therapy, help these patients in some way. Some years ago, we would routinely do a catheter into the liver, a liver catheter we called it, through a surgery. And the idea was to do directly into the liver circulation to deliver chemotherapy. So that had good rationale to it because this was not systemic therapy. This was treatment which went directly into the liver with a drug which is very similar to Xeloda. It's called 5-FU. And we used that for many years. And the strategy was moderately successful, but with the advent of Xeloda, which is very similar to this 5-FU drug, and because it's a pill and because it has a low side effect profile, we started using this medication and the results were very similar. And so obviously this meant that we didn't have to do invasive procedures to our patient. We didn't have to do surgery. Now, interestingly, there was an article, a study that showed that compared high-dose Xeloda patients to low-dose Xeloda patients. And that the conclusion was that there was a very important overlap area in which patients did very well whether they were on high dose or low dose. The results of high and low dose were very comparable, so we said, great. That means we don't have to use high dose regimens, and we already were tending to use low dose regimens, and that was a very good support for our impression that we could use low dose chemotherapy. And so what we started noticing when we started using this drug is that sometimes the results were so dramatic when we used it that the impression was that the response that our patients were getting were not solely attributable to the Xeloda therapy. Because, Xeloda is a single drug, and it's a very good drug, but sometimes the degree of response that we would obtain on the short term was very impressive, So then our thinking was, well, that means that there's very likely synergism. That is, everything else that we're doing within the naturopathic realm is contributing to this low-dose chemotherapy becoming more effective, becoming more intense in effect. And so, if this were true, we thought, that means that we could use this drug not only where it was generally recommended through the oncology experience in breast cancer and colon cancer, but if it's true that the vitamin C therapy, the ozone therapy, the hyperthermia therapy, the diet, they're all contributing against the disease in conjunction with Xeloda, that means that we might obtain results in cancers in which there is absolutely no medical support for the usage of Xeloda. So we put this to the test. And we started using this drug in combination with our therapy. We started using it in cancers in which there was no clinical experience for its usage. And the best example for that was a gentleman from Canada. He was originally from Nigeria, I think. He was a immigrant to Canada. And he came to us, a young man in his 30s. He had liver cancer. He had hepatocarcinoma, which is a liver primary, not metastatic disease from a colon cancer, not cancer which initiated in the breast or in the colon and then went to the liver. No, this was a liver cancer, a liver primary. And liver primaries are distinguished because there is no chemotherapy. There's nothing in the books, or at least there wasn't then, that had any potential to benefit this patient. Nowadays, they use intraarterial chemotherapy. They do it directly into the liver. They do radiation therapy particles into the liver. They do some targeted therapy, and results are still, not extremely encouraging. But way back then, I'm talking about 10 years or more, there was nothing of that would be considered useful in liver cancer. So this gentleman, this very young gentleman, he came to us and his liver was overwhelmed with liver tumors, and his on the X-ray, his liver would remind you of a bag full of marbles. It just looked completely covered by tumors. So we thought, well, this patient's prognosis is very poor on the short term. So if we're gonna help him, we better do everything that we have available to help him because we're not going to get a second chance with this patient, not because of his liver status. So that was one of the opportunities in which we started using this drug. And again, at that time, there was absolutely no support in the medical literature for the usage of this medication. So we used the medication, we used it in combination with everything else that you are doing, and 3 months later, the patient comes in and his liver is practically clear. 1 or 2 marbles left. You know, nothing short of a miracle. And so this strengthened our impression that it's not the chemotherapy per se, but it's basically the combination. Therefore, at the Oasis of Hope, we feel that the best chance to beat cancer is not any one-on-one therapy. It's the integrative approach. It's the bunching up. It's the multiple elements of therapy working in conjunction. It's a team effort. We feel that is the best chance that our patient has of getting a positive response against disease. So, what's going to happen if a patient sees our prescription and says, "What's that?" "Well, that's chemotherapy." "Oh, I didn't come for chemotherapy. If I wanted chemotherapy, I would have stayed at home." Well, his name was Biquinquita. Mr. Biquinquita would have never gotten Xeloda at home, because even now there's not a lot of rationale, there's not a lot of clinical experience using Xeloda in lung cancer. And if Mrs. Stefanescu, who's around today, you might get a chance to talk to her son, because she doesn't speak any English. She's a lung cancer patient on Xeloda, and having the response after 3 months is excellent. And if you go to the medical literature and try to find something that supports the usage of Xeloda in lung cancer, you won't find much, if anything. So, be on the lookout, be aware of any inclination that you might have in regards to trying to keep your treatment very pure, very strictly within the naturopathic realm, which is reasonable. Everyone has heard, everyone has experience with people who've done chemotherapy and have done terribly. Chemotherapy was much worse than the disease. So most of you have a concept that that's chemotherapy, that doing chemotherapy is probably something that means you're going to die very soon, and that you're going to die in suffering. That's the impression that you have. So that's why we are here discussing this particular element of chemotherapy, which features the fact that it's a pill. And mind you, if we did not tell you that this was chemotherapy, you would never know. Though that's not the way we work at the Oasis of Hope. We want our patients fully in conjunction with the decision making, and we tell them what we're giving them. But truly, if we did not tell you that this was chemotherapy, you wouldn't know, because there are practically no side effects. There's no hair loss, there's no nausea, there's no vomiting. Some patients are sensitive, so they will require adjustment. But the great majority of patients will have no side effects to Xeloda therapy. Most of the side effects are related to the bunch pill taking, not particularly to the Xeloda therapy. So, again, I emphasize the fact that a lot of you will be surprised, a lot of you might even be shocked that at the Oasis of Hope we're talking chemotherapy. It's a bad word, chemotherapy. Well, now you know that it's not. Now you know that what we're trying to do is to beat cancer by doing it, by bunching up against it. It's a team effort. And if you should decide to not do that particular element of therapy, even though we have recommended it to you, then you will be doing the less than an optimal team, so to speak. It's like putting in a bench warmer for someone like Michael Jordan, for example, if we have to substitute, you know. So be very mindful, very mindful of that. Remember, therefore, Zelototherapy is low-dose chemotherapy. It will likely put a knife in the hand of your treatment so it can make it more aggressive. And in many of you, aggressive therapy is required because you have aggressive disease. And so you have to treat the cancer exactly the way it demands to be treated. You know, there are not a lot of mild-mannered cancers, so you have to be very aggressive. And the team approach, the integrative approach, the bunching up against the cancer is likely the best chance that you have at beating the cancer. Are there any questions so far? Let's go to a second drug which is going to be on your list. The drug is called Metformin. Many of you are familiar with it. Metformin is one of the most commonly used drugs in the world. It's one of the most prescribed drugs in the world. Does anyone know why? Why Metformin is one of the most... It's an anti-diabetic drug. And since diabetes is so widespread, it's one of the most prescribed drugs. Therefore, when it was tested in regards its ability to act against cancer, large group of patients were able to be compared. There was a study which had 3 groups, and each group had more than 1,000 patients. And they compared breast cancer patients, diabetic breast cancer patients on insulin, diabetic breast cancer patients on metformin, and non-diabetic breast cancer patients. And they compared them for statistical outcome. So guess which one of this group did the best? It was the group on metformin. The metformin group did better. And subsequently, there's been a lot of research in this regard. So apparently, what metformin is doing quite independently of its effect on blood sugar, what it's doing is to inhibit or kill cancer stem cells. Listen carefully, cancer stem cells. You've all heard of stem cells and how they can be used to treat chronic degenerative conditions, when they put stem cells in your brain to treat Parkinson's, to treat Alzheimer's, to treat spinal lesions. They put stem cells because stem cells will turn into the cell which is in which the area that they are seated. They can turn into a brain cell. They can turn into a red blood cell. They are basically mother cells, so they can give rise to, they differentiate into a specific cell and then give rise to a whole progeny of brain cells, red blood cells, etc. But we're not talking stem cells, which are, its main usage today is for what's called rescue therapy after bone marrow transplantation. If you haven't heard of that, it's a very intense therapy that's used typically for leukemias and lymphomas. What they do is they will do lethal doses of chemotherapy and radiation. And why are they lethal? Because they will wipe away your bone marrow, where the red blood cells, the white blood cells, and the platelets, which are important in clotting, this is where they live. This is where they are produced. So when you're getting stem cell therapy or stem cell rescue therapy, they will kill off the bone. The lethal doses of radiation and chemotherapy are given to kill the cancer. They will also kill your bone marrow and your bone marrow reserve. So what then? Then they take the stem cells that were previously removed from the patient's bone marrow and put them in the bone marrow for the repopulation. So these stem cells, again, are able to convert into the cell which is required. But we're not talking those stem cells, we're talking cancer stem cells, which means that there's a certain population in any tumor, maybe if it contains 20 million, 30 million, 40 million cells, 0.1% of that tumor population is going to be stem cells. So when you do therapy, when you do chemo, radiation, or even our treatment, and you kill off the great majority of this cancer cell population, the residual, the 0.001% that is left is likely to be stem cells, cancer stem cells. So this is the seed. This is the root. This is the origin of the cancer coming back. And when it comes back, now it comes back with a different cell population. This different cell population is now resistant to the previous therapy. It will not respond to it because it's made up of a progeny of a survivor of two chemotherapy. So that it's no longer possible to treat it with the same treatment. That's why in chemotherapy, when you get a disease recurrence, especially an early disease recurrence, you will not get treated with the same chemo. You need to move. You need to go back to another one, and subsequently, each time you have to do a different therapy because now when the disease recurs after treatment, it is considered to be resistant, and that resistance is mediated through cancer stem cells. So it turns out that metformin is adverse. Metformin will kill cancer stem cells. So when we're doing metformin for you on your treatment, what we're doing is, with everything that you are doing, we're killing off we're trying to kill off the cancer, the tumors and the cancer population. But we're also trying to kill off this tiny percentage of cells which constitute the stem cell population, which is likely to be the source of a disease recurrence. So in essence, we're giving you treatment and we're giving you anti-resistance therapy. So that means that when we obtain a response, in 3 months when you come back and we show you that you've had a positive response, then if we are doing anti-resistance mechanisms, we're also trying to guarantee that the cancer is not simply going to come back after a short while, because we've also been doing therapy that antagonizes its ability to resist therapy. Therefore, your treatment, your results can be long-standing. They can be maintained over the long term, which is something that unfortunately chemotherapy does not guarantee. So metformin has nothing to do with blood sugar control. When you see it in your list, it's not there because of blood sugar issues. In fact, metformin does not lower blood sugar in non-diabetics. It only decreases the blood sugar in diabetics because it stimulates the receptor in the cell for blood sugar. So that means that when metformin is in action, the receptors for blood sugar will be stimulated or will be have more production, so that more blood sugar molecules are obtained. But if you have a normal blood sugar count, then the effect of metformin will not be to increase that and then lower your blood sugar. So in the long experience that we have with usage of metformin, I can count on my hand probably 2 or 3 people who actually had what seemed to be low blood sugar reactions to metformin. The great majority, hundreds of patients in which we've done metformin therapy, do not display any suggestion, any evidence that their blood sugar is getting low. Metformin is not an easy drug to do, and we will, if you recall, your prescription has 16 elements to it, but it's divided in 4 groups. And each one of the groups has one of these elements which might be harder to do than your nutraceuticals. So it'll be easy for us to determine whether you're having trouble with metformin or not, or any of the other drugs. Their prescription is written in a fashion that it allows us to focus on the likely culprit if you are getting adverse effects. So, you know, again, if you have assigned to us the very high responsibility and confidence to treat you, you know, and I kind of get, you know, when one of our patients say, you know, they've come far, they've done research, they know that we're giving them our best effort, they've assigned us a great responsibility and confidence, and then they'll say something like, well, I don't want to do that because it's not natural. And you say, like, come on, you know. And so any reaction of this type I want to do here, like, what? I don't want to do that in our consultation. Our consultation outside, okay, you know, you don't want to do it? Are you sure? Because this is what we feel is the best option for you. But here, you know, when I see something like that, when I hear something like that, I say, hello. You know, this is the combination in which we've had much success. And yes, some of the elements in your list a particular patient will not be able to do. Does that mean that you may not expect a good response? No. Because if for any reason you can't do one or two in the therapy list, there's a lot of redundancy in the treatment so that several drugs take care of the same responsibility. So if you're not on this particular drug, other drugs may take over that responsibility. So if you can't do one or two drugs, that doesn't compromise the likelihood that you're going to have a good response. But it's different when a patient tries it and it's clearly demonstrated that, you know, they can't do it. Their body doesn't accept it, and that's different. But if a patient doesn't even want to try it simply because of misinformation, prejudice, or the idea that if anything doesn't come directly from the health food store or from the organic food store, that it shouldn't be part of your treatment, well, that's a mistaken, as they say in your where you come from, that's horse and buggy thinking. Okay, the modern therapy is based on many years of experience and the careful development of an integrative approach, which again is likely the best chance for you to have a good response against disease. Any questions so far? Good. If I am confusing you in any way, or, you know, sometimes no questions means not that I understood everything, but I don't understand anything at all. So I hope it's not the latter. There's a third drug in your treatment list. ¿Cuánto llevamos? No es cierto. ¿Sí? Okay. There's a third drug in your list. It's called Celebrex. Can I see some hands? Anyone who knows Celebrex? So when a patient sees Celebrex is a widely used anti-arthritis medicine. Widely used anti-arthritis medicine all over the world. It's not one of the most used drugs in the world, but it is very commonly used, particularly for arthritis, rheumatoid arthritis, and similar conditions. So when a patient sees Celebrex on the list, it'll say something like, well, doctor, I'm not in pain. Why are you giving me Celebrex? Or, doctor, I don't have arthritis. Celebrex is a drug which is called a COX-2 inhibitor. COX-2, or COX stands for cyclooxygenase, the cyclooxygenase 2 enzyme. Cyclooxygenase is a mediator of inflammation. It's a particle, it's a substance, it's a molecule that when present in the environment, it induces a certain metabolic machinery that produces inflammation. This can be positive when you are responding against an invader, or it can be negative when inflammation is simply occurring because of a pathological process. So, because it's commonly used, getting back to COX-2, it turns out that the COX-2 molecule is not only a mediator of inflammation, it's also a growth factor in cancer. It's a cancer growth factor. What does that mean? Growth factors in cancers are molecules, are substances which cancer produces for itself in order to stimulate. Growth factors will stimulate growth, tumor growth, will stimulate cancer spread, and will also stimulate this, resistance to treatment. These behaviors in some very aggressive cancers are mediated by cancer growth factors. It's like an executive order. It's like a president signing an order for a mobilization. So they take this order and they hand it to the generals, and the generals say, the president says that we need to mobilize more. So they start building more tanks, more planes, more weapons. That's how a growth factor acts. It induces the formation of more proteins, more enzymes, more DNA chains, so there's more cancer growth. And it enhances a particular pathological behavior of a cancer, which can be very aggressive spread. These behaviors are mediated by growth factors. So our treatment consists of growth factor inhibitors. We are targeting growth factors. There are many growth factors in cancer. It is very difficult to address each one of them. But there are a lot of growth factors which are very well known, which play a major role in most cancers. This is the case of NF-kappa B. This is the case of IGF-1. This is the case of COX-2. This is the case of 5-LPO. These substances have been shown to be stimulators, to be messengers for disease progression. So if you inhibit the transmission of the message, if you inhibit the activity of growth factors, that will have the opposite effect on cancer. There will be no stimulus for progression. There will be no stimulus for making more proteins, which are building blocks for cancer. Proteins are building blocks for cancer cells. So the more proteins are available, the more cells will reproduce. So we're shooting at the growth factor. Years ago, there was a clinical study that showed that patients who had familial polyposis in the colon, there's a condition in which patients have a lot of polyps, literally hundreds of polyps in their colon. This is a genetic condition. And these polyps within your colon, they're pre-malignant lesions. So in these particular people, it is almost a certainty that by their 30s or 40s, they're going to have a colon cancer. So most of these people need surgery in order to prevent the possibility of cancer. Well, it turned out that when they studied people with familial polyposis, and some of these patients also had arthritis and were being treated with Celebrex, were being treated with COX-2 inhibitors. And what that study showed that there was a difference between the incidence of cancer, of colon cancer, in patients who were not treated with COX-2 inhibitors and patients who were treated with COX-2 inhibitors. And when they would check these patients, they would notice that the polyps would go away. In many instances, from having hundreds of polyps, the patients would now have a few. So the COX-2 inhibitor was also inhibiting the polyps. Again, pre-malignant lesions. And so that led to the finding that the COX-2 enzyme is also a growth factor in cancer. So if you inhibit COX-2, the COX-2 enzyme, you're also inhibiting the cancer machinery. Not all cancers have COX-2, not all cancers have NF-kappa B, not all cancers have IGF-1. And if you inhibit, in cancer, particularly cancer, if you inhibit one growth factor, it'll turn around and take another route, another metabolic machinery. That's why cancer is so difficult to treat, because you block one route for reproduction, and the cancer comes up with another one. And we already discussed how we're trying to handle that through inhibiting disease resistance. But in regards to treating cancer, in your list, there are several elements of therapy which target the more well-known growth factors in cancer. Say, for example, the Celebrex targets NF-kappa B, the Boswellia targets the IGF-1 particularly. So we're not sure, we can't measure which growth factor is particularly predominant in your particular case. So what we have to do is kind of like across the board inhibition, growth factor inhibition, a shotgun type approach by doing many elements which address each one in particular, so that the likelihood that we are covering the element which is active in your particular situation is being well addressed. So again, Celebrex is a drug. It comes from the pharmacy. It's used mainly for arthritis. It can be used for pain, but in our setting, it's used as an anti-cancer substance. So that's why it's a growth factor inhibitor, a very important growth factor inhibitor, especially if you have colon cancer. And that's why it's on your list. Any questions so far? Ya me cansé, amigo. ¿Le seguimos la otra semana o qué? ¿Sí? No, falta el Alin, ¿no? Ah, no, el Alin ya te lo di. Ya lo tienes.
So you said Celebrex, it's a
growth factor inhibitor. COX-2 block. Sir?
It hinders the growth.
It hinders. It hinders.
I've seen it advertised on TV, Celebrex.
It's a off-label usage for the drug. It's off-label. The main label or the license for the drug is for arthritis. Right. Off-label, it can be used for growth factor inhibition in cancer, especially in colon cancer. That's true for Metformin, off-label usage. That's true for Xeloda, off-label usage, because we're using it in conditions which have not been researched or authorized, say, for example, by the FDA.
But you have seen the results positive.
Absolutely. And in that regard, when we have a successful therapy trial, we don't know for sure which element is predominant. But our impression is that it's actually the bunching up. It's actually the group effort.
So the holistic approach.
In conjunction. But do not misinterpret. You know, when somebody hears holistic approach, they usually think it's strictly natural, and holistic is a word that it mainly signifies everything, all. So in this case, holistic means that we're using naturopathic elements and pharmaceutical elements. That's a holistic approach, you know. And some people will say, well, I want to be holistic and only use stuff from the health food store and from the organic food store, and that's a mistake. In our viewpoint, that's a mistake. So we're pointing it out very clearly here, so that we don't have to be harsh on you when we speak on the on our consultation, okay? There's a drug called dexamethasone. It's a cortisone-like drug. If you know anything about cortisone-like drugs, you know that, well, cortisone are very potent anti-allergy medicines. Cortisone are very potent anti-inflammatory drugs. The first thing they do when a pro athlete gets a strain, a knee strain, a back strain, something like that, what do? They inject cortisone. And why do they do that? Because it's very potent anti-inflammation. So the effect might be immediate, so that the athlete is very likely to be ready to go back to play the next day or the next week. It's very effective anti-inflammatory therapy. It's also very effective anti-allergy medicine. Anyone gets the hives, severe allergy, the type of allergy that kind of closes your airway, like with a bee sting or something like that, and they'll use adrenaline, but they'll use a very high dose of a cortisone-like drug. So they're very useful drugs for these purposes. And it used to be that cortisone and cortisone-like drugs were abused, because people who had arthritis, chronic arthritis, the ones that require people taking aspirin every day for years, you know, and patients would try the shortcut. Patients would try the quick fix, and this was steroid. But that led to, you know, and the effect of a steroid would be immediate. The patient would feel great, but after a week or two, they had to have more steroids, and then more steroids and more steroids. And steroids have serious side effects. Over time, they will cause high blood pressure, high blood sugar. They will make your bones brittle. They will make your skin brittle. They put you at risk for bleeding in your stomach or bleeding in your brain. So years ago, we saw many people die, arthritis patients. Many die from what's called Cushing Syndrome, which is the end result of cortisone abuse. And doctors would abuse it, and patients would abuse it, because there was no regulation. And again, people just got accustomed, got used to the very quick and efficient effects of the steroid. But this was only a quick fix. It wasn't of any useful for long term, because ultimately the side effects of the drug will kill you. And anyone who knows this, when they see that on the treatment list, when they see a cortisone-like drug such as dexamethasone or Allen in the list, is going to say, "Well, doctor, that's a no-no. Cortisone-like drugs are a no-no. We shouldn't do that, because they are immune suppressive, because they're going to make me bleed from my stomach. They're going to inhibit my adrenals, etc., etc." And you would be right, generally speaking. However, because steroids have a very potent anti-inflammatory effect, and it turns out that growth factors in cancer are very strongly pro-inflammatory. IGF-1, NF-kappa B, COX-2, and any of the other growth factors in cancer are very strongly pro-inflammatory. Cancer is an inflammatory disease. And the extreme manifestation of that is a condition called cachexia, cancer cachexia, in which there's extreme muscle wasting. And these are the growth factors causing inflammation in the muscle cells. In the muscle cells, they just die off. And people tend to think it's because they're not eating. People think because it's the cancer eating up their muscles, but it's actually an inflammatory condition mediated through growth factors. So the steroid, the cortisone-like substance that we are doing, is directed against growth factors, and not one in particular. Through the steroid, we're doing across the board growth factor inhibition. Well, is the trade-off with the possibility of side effects? worth that effort? Well, I can tell you that the strategy we've used for years, and the minimal dosages, the very tiny dosages that we're using, of the steroid dosage that we're using, is too small to cause those side effects. It's probably too small to do anything against cancer. If you were doing that against cancer only, it probably wouldn't do anything. But again, as part of an integrative approach, as a bunching up of cancer, every little bit helps when you are doing multiple elements which are contributing. So our patients, our long-term survivors are doing Allen, they're usually doing it for a year or two. We've had no problems with blood pressure. We've had no problems with blood sugar. We've had no problems with bone, so the side effects from long-term steroid usage at that dosage range, we have not seen. So in our viewpoint, it is a safe treatment strategy. In our viewpoint, it is an important contributor to the group effort. And so that's why it's on your list. And again, the key to success against cancer is to hit it on multiple fronts, multiple bunching up against the cancer. So that's part of the group effort. There's one more element in your list, and that's called WOB enzyme, digestive enzymes. The effect of digestive enzymes in cancer are theoretical. There are multiple proposed effects. But the strongest reason that it's in your list, digestive enzymes, WOB enzyme, is because when Dr. Contreras started using laetrile therapy, 53, ¿cuántos años son? 53? 53? 53 years ago, 63. Son 60 años. No? My math is off. It was 1963. All right. He started using laetrile in 1963. Soon after he started using laetrile, he started using digestive enzymes in conjunction with laetrile. Now, what was the rationale? Nowadays, when digestive enzymes are marketed for as a digestive aid, they're also marketed as anti-inflammatories, especially for soft tissue inflammation. When Dr. Contreras used it in conjunction with laetrile, the assumed benefit was that digestive enzymes would tend to break down the lining or the protective layer that prevented the laetrile to come into a cancer cell. These are theoretical issues, but the key point is that Dr. Contreras started using, and I'm not talking about Dr. Contreras Jr., I'm talking about his father who started doing treatment in 1963. And for that long, he was using digestive enzymes along with laetrile therapy. So that's a very strong reason for us to keep doing it, not to veer away from it, even if we can't give you a clear explanation of why they should be beneficial, why they are beneficial. It is likely that they contribute as anti-inflammatories. Again, remember, cancer is a strongly pro-inflammatory disease. So anything that you're doing in the opposite direction as anti-inflammation is likely to contribute against the disease. So that's why digestive enzymes are in your list, because they're likely contributing as anti-inflammatories, and because they have a great track record based on their history of being used in conjunction with laetrile for many years. Very good. I think we've covered all the elements all the non natural elements in your prescription. All of the elements which come from the pharmacy and not the health food store.
Are these all effective against the triple negative cancer?
Absolutely. Again, it's the group, it's the team. I wouldn't do one-on-one treatment against cancer with any situation. As strong or as good as one treatment can be, doing one-on-one therapy is just putting a big challenge, a very tall order for any treatment, as good as it may be. The idea is to bunch up against the cancer and not let it develop resistance to any treatment, as good as it can be.
Do you ever use berberine in your treatment?
Berberine is a substitute for metformin, but it does not enjoy the it does not enjoy the
Same action?
the record that metformin has. It's probably okay to substitute it for blood sugar control, but is it going to have the same effect on cancer stem cells that metformin does?
Don't know.
Nobody knows. So we don't take that risk. Thank you very much for your attention. If any other issues need to be covered, we'll be covering that at your consultation.